everyone a few minutes to make sure they're logged in, make sure their sound is working, and then we'll get started. Welcome, everyone. I see more people are joining, so I'm just going to let those participant numbers rise up before we get started. All right, more people may be joining, but we're going to go ahead and get started. Thank you all so much for joining us for Stopping the Syndemic, the role of tech to ensure cardiovascular health in the COVID-19 era, co-hosted by Devex and the Novartis Foundation. I'm Catherine Cheney. I'm a senior reporter for Devex, and I'll be your moderator today. So we all know that in addition to the direct health risks of the COVID-19 pandemic, the indirect effects of the virus include severe disruptions to basic health services needed to prevent, diagnose, and treat patients with noncommunicable diseases. People around the world are facing severe disruptions to care, preventative screenings, postponed surgeries. And as we'll discuss today, this has really created a ticking time bomb when it comes to cardiovascular health. But we've also seen over the past year how digital technologies can make services to address chronic diseases, such as cardiovascular health, more effective and affordable. And today, our focus will be how can the global health community build on this momentum of increased use of and trust in virtual health and care services in order to leverage this technology to improve cardiovascular population health, especially in low and middle income countries. So while it's been a devastating year in terms of health impacts, it could also be a turning point in terms of the use of technology. And I'm looking forward to discussing that with our panelists today. This event is part of the Health Tech Dialogue Hub, which shares lessons on technology-enabled innovations, hosts events, and facilitates ongoing dialogue between government leaders, healthcare workers, and innovators like all of you. So thank you for joining us. We look forward to hosting more events throughout the year on how to catalyze artificial intelligence-driven solutions, AI-driven solutions for health and care delivery. Before our panel discussion, I'd like to go ahead and introduce my colleague, Amruta Bietnal, for a conversation with the president of the board of the World Health Federation on the importance of data-driven decision-making to improve heart health.
Hello, everyone. I'm Amruta Bietnal. I'm an associate editor here at Devex, and today I'm joined by Professor Fausto Pinto, who's the president of the board at the World Heart Federation. Welcome, Professor Pinto. It's a great pleasure to have you here. I know we're talking about COVID and cardiovascular diseases, so I'm just going to get started and ask you a very basic question to begin with. So, what has the pandemic been like for cardiovascular diseases? And, looking from your vantage point, what are the kind of innovations that you're seeing on the ground?
Well, thank you very much for the invitation to be here with you. It's a real pleasure. And talking about a subject, which is one of the subjects that we're talking about more often nowadays, which is the impact of COVID-19 in cardiovascular diseases. And I think we can divide in the direct impact and indirect impact of the pandemic into cardiovascular disease. If we look at what this virus can do to the cardiovascular system, we know already a lot about it, and we know that it can have major implications in the cardiovascular system, developing some forms of disease like myocarditis, like heart failure. We know that it can also develop prothrombotic conditions that can evolve into pulmonary embolism and other forms of clot formation in the body. We know it can also, together with some other elements, be responsible also for some of the conditions that we see, for instance, in the lungs or even in other cardiovascular areas, like, for instance, in the brain. The whole vascular system seems to be, in some cases, very aggressively attacked by this virus, developing some sort of what we call endothelitis. So we know there is, in a percentage of patients, direct impact of the virus in developing cardiovascular disease or inducing cardiovascular disease. We also know that patients who already have cardiovascular disease, they are more prone to the infection And also when they get the infection, they actually have a higher chance of developing complications. So on one hand, we may have patients who had no previous disease, who develop cardiovascular disease induced by the virus. On the other hand, we have patients who already have cardiovascular disease, who are more prone to the disease, and who may develop more complications by being infected with this virus. So all these are the direct implications of the virus. The indirect implications of this pandemic, which is also a very important problem, is the fact that around the world, there was some sort of, these patients, there was some sort of neglect of cardiovascular disease. And what we've seen this in my hospital, in my country, and in the countries around the world, in average was up to 58% reduction in the number of patients coming to the hospital. There was a significant reduction in the patients coming to the emergency room. And the implications of these was the fact that there was an increase in overall mortality. So we can observe now, and we have data that shows there is an excessive of mortality around the world with some differences, but not major. And on the other hand, even the patients who came to the hospital, because they were coming at late stages of disease, they were coming with more severe forms of disease. So the mortality actually was higher, for instance, for acute myocardial infarction or for stroke. There was, in some cases, three to four-fold increase in mortality for a condition that can be treated if it's treated in the right timing. And that's something that really worries us, which is the fact that it's not only the, again, the direct impact of the disease, but also this indirect impact, which has another implication, which is the fact that many of these patients with cardiovascular conditions, they have not been totally well treated or managed over this period. So we are very much concerned with what we call the tsunami that will come with very significant cardiovascular disease coming over the next few years. And that's something that as a community is really worrying us very much.
And then, you know, this is such a crucial issue. And as you said, in the coming years, the impact of it will become even more obvious. So how does data play a role in this? And how do you use AI-driven approaches to actually identify some of these diseases? And what does that data collection actually look like on the ground?
Well, data is knowledge. And we know today with tools of data mining, of data science, using artificial intelligence can help us to understand much better, on one hand, the phenomenon that happened, and we are now dealing with this problem. It can be applied to other problems, but this is the big problem that we face as a global society. And the capacity to analyze, to obtain and then analyze that data can provide new tools, can provide new solutions for some of the problems that we are facing. So on one hand, it will help us to understand better the whole condition. It can help us to understand also what are the gaps, what are the needs around the world, because although it's a global problem, but the way the problem reflects in certain parts of the world is a little bit different from other parts of the world, sometimes even within the same country. And that's something that having the capacity to analyze that data, to have that data, can help us to, again, to understand better, to identify better some of the problems, and to develop maybe better tools to manage these patients. So that's the big challenge, is to be able to organize, and there's a lot of ongoing, and in many parts of the world, with registries, with studies, with a lot of data gathering that is being organized. And what we want to achieve, and particularly now speaking as WHF in cooperation also with Novartis Foundation, what we want to achieve is to be able to collect a lot of this data together with our members, together with, because we have the fortune of having, on one hand, scientific societies as our members and foundations. So there's a whole lot of current projects that are being developed around the world that we can work together with these members and be able to get that data, and then by analyzing that data, map the different questions and the different elements that we want to look at, and with that be able to get new information and do better. At the end, what we want is to establish better ways to do better patient management.
Right. And the partnership with Novartis Foundation that you talked about is the global observatory, right? And you're collecting data from across different countries. So I'm wondering, what is the role of frontline health workers in this data collection, and how can they be empowered to understand the process better and, again, help in sort of feeding back the data in the right way? Is that something that, that efforts that are ongoing?
Yeah, that's very, very important, because data is knowledge, as I mentioned, but the quality of data is also fundamental to create trust in this type of projects, and the way all this is processed is very important. And that's why we rely very much on our members, members that can be the American College of Cardiology, American Heart Association, European Society of Cardiology, Japanese Circulation Society, Brazilian Society of Cardiology, heart foundations around the world, where they really have organized registries, some of them already with many years of ongoing work, and adapted some of these projects to the current situation, and particularly with the COVID situation. But we are not only interested, of course, in it's very important, and of course that will be one important element, but we are interested in global cardiovascular issues and as a whole, in terms of getting information around the world on different elements that can, again, be useful for us to map what is currently happening in the world, and with that be able also to identify some needs, some gaps, and be able to work together with our members and with those regions, with those countries, to try again to identify new ways of improving cardiovascular health. Our motto is cardiovascular health for everyone, and that's what we pursue. It's of course very, very much an ambitious project. It goes aligned with WHO and many of the goals that have been developed by WHO, and we are very much aligned with that, particularly the one that the goal is to reduce by 1/3 in 2030 cardiovascular diseases, and that's certainly one area where we're working very much with our members. And again, by organizing something like the observatory, will basically enable us to have the information that can help us to find better tools and find better ways to achieve those goals. So in brief, that's what we're developing, what this partnership, we're very much very excited into this partnership, because certainly partnering with a structure like an organization like the Novartis Foundation, together with Microsoft and Accenture and some other areas that can be very useful in the way that this data collection and data mining can be organized. It's certainly a very exciting project that we're very much looking forward to implement it and to develop even further. And this is a long-term project, so it's not only for the moment, but what we are launching is actually looking into the future as a long-term project, as an observatory should be.
That's really insightful. Thank you so much. One last question for the day. If you could just talk about the challenges of collecting these data in the global south and how organizations like yours are trying to address that. We have 1 minute left, so we can just end with that question.
Well, I think the main challenge is guarantee the quality of the data, is to work with our members, engage our members to be engaged in the project, so we can be successful in gathering all the information and be able then to get the results. So I would say that the quality assurance, together with the engagement of our members to be engaged, involved in the project, are, I would say, some of the most relevant challenges. There are others, but these will be the ones that I feel that to start with can be very important to overcome, and I'm sure that we will overcome those and be very successful for the future.
Right. Thank you so much, Professor Pinto, for this insightful conversation. We at Devex will keep following, the work that you do and the work that your partners do, and we'll keep coming back to you. Thank you so much.
Thank you very much. It was my pleasure. Thank you.
Thank you both. And as you just heard, Dr. Pinto is president of the board at the World Heart Federation. I mistakenly said the World Health Federation, mixing up my words in this discussion on heart health, so I apologize for that. But that conversation captured why we're calling this event Stopping the Syndemic, because of this convergence of pandemics, with more people dying of cardiovascular disease and other heart conditions due to the indirect effects of the COVID-19 pandemic. Dr. Pinto also discussed some of the ways that digital health has helped to deal with service disruptions caused by the pandemic. And moving forward, as we all know, digital health services are here to stay. They're likely to become mainstream. So in addition to telehealth consultations, digital technology can help with the triage of patients, with screenings to detect risk factors, as well as patient engagement in the management of their own care, as you just heard. And data and AI solutions can really help to automate many of these services. So with that, I'd like to introduce several panelists who can expand on the ways that data and digital can help to mend the gaps in prevention, diagnosis, and management of cardiovascular disease. And I'd like to encourage our audience to submit questions using the Q&A function. We'll get to those as we're able. I see some of those audience members joining us in Zoom or sharing where they're from and what they want to bring to this conversation, and we love to see that. So please keep those questions coming and we'll get to them. I'd like to briefly introduce Dr. Nneka Mobison, co-founder and CEO of Mdot, Dr. Edson Amaro Jr., who's a neuroradiologist and head of big data analytics at the Albert Einstein Hospital in Brazil, and Farouk Merali, who's the founder and chief executive officer of mClinica. So I'd like to start with you, Nneka. Mdot leverages behavioral science in its web and mobile-based technology to optimize this end-to-end care experience for people living with diabetes, hypertension, and cancer. And I'm wondering if you can expand on some of your learnings that could apply to this question on the role of tech in ensuring cardiovascular health moving forward.
Thank you so much. We've learned a lot at Mdot. We've been around for 4 years now. And pre-COVID, we were met with a fair bit of skepticism from the broader global health community about the utility of digital and its scalability, especially for areas such as cardiovascular health in low and middle income countries. So our learnings, while they're constantly evolving in the context of COVID, at a high level have remained the same. And they primarily center around the fact that digital technology does work in low-income populations for providing self-care support for hypertension, diabetes, prediabetes, obesity, and more. So at Mdot, our theory of change is that a fusion of digital nudges through an omni-channel digital platform that can truly meet people where they are and support them through a coach-led multidisciplinary team can ultimately lead to sustained behavior change, which will drive population health outcomes. Today, we have about 20,000 members living with or at risk for chronic disease across Nigeria. And at enrollment, approximately 70% of them are overweight or obese. They engage with our virtual coaches through our platform, Complete Health, which integrates online peer groups and teaches them how to self-monitor their metrics, so the data that we heard Professor Pinto talking about, such as blood pressure, glucose, waist, circumference, BMI, and also receive nudges on how they can make the right choices from a behavior perspective. In our members today, we've seen an average increase in exercise duration from 28 minutes to about 84, which is not at all near WHO's recommendations, but we're getting closer by focusing on what we see as the key ingredients for change in terms of leveraging digital in the vulnerable populations that we serve. So first, investing in trust through personalized digital interactions. You mentioned trust earlier, based on a member's preference for where they want to be met, whether it's SMS or Telegram or the chat function on our platform. And then two, it's investing in building e-health or telehealth literacy. And because the reality is that smartphone penetration rates and mobile phone penetration rates are not appropriate proxies for digital literacy, which can be a major barrier, as we've seen. And then three, really key to invest in self-efficacy so that people feel confident and empowered to make the key lifestyle changes they need to improve their cardiovascular health. And we've seen this works. In our members with hypertension today, there's been an average decline of 8.3 points in average systolic blood pressure, which translates into a reduction in terms of their premature mortality risk. And then lastly, more broadly speaking, we've learned that driving population health outcomes when it comes to cardiovascular health require an integrated care approach. So while we focus primarily on self-care and don't replace the care of clinicians at Mdot, we also invest heavily in teleeducation of providers across the country and now increasingly across Africa to increase the likelihood that when people do go to facilities for care, they're more likely to receive the right kind of care at the right time, in the right manner, all the time.
Sorry about the pause there. I was taking notes as you were speaking and had to switch windows here. So many takeaways for me. And one is when you mentioned this point that mobile phone penetration rates are not the same as digital literacy. That's of course always been true, but the need to recognize that and work to address that is all the more urgent now that these health services are moving to mobile platforms, or else we can't harness this momentum we were talking about earlier. So thank you so much for those insights. I want to bring Edson into this. And Edson, I'm wondering if you can expand on your work on big data and how it informs your view on the role that tech can play in stopping this syndemic, as we're calling it.
Oh, thanks for the invitation. Here in Brazil, what we did was to work with the government, the federal government. So it's a project that we run for the government. And the idea is actually to maximize the potential of big data analytics technologies into the public health sector. So we work within the public health sector in small communities in the country. So our experience was first on data acquisition, how we manage data acquisition. And there are platforms in the country that has been there for quite a while. So we wanted to expand those capabilities of accessing data based on health information. So one interesting point is that we run a risk assessment questionnaire over the phone, so trying to mimic what the government does only at the capitals of the 27 states in Brazil. So we did that in small cities. We expand the range of connections, and an interesting thing that connects to what Nika just mentioned, when we compare the prevalence of self-reported hypertension of mobile phone users to a fixed home phone users, when we call them, it's actually different. It's around 10% difference, and that implies in that has many implications across the country, because we've been using only fixed phone calls in a program that's run since 2006 in the country. So this is one thing. The other point is that we've been using the community health workers. These are a major strength in Brazil public health system. So these people are from the community. So they work in the same neighborhood of the patients that are in the public health system. So in other words, these are people from the same community, and they are using now tablets in a very poor area of the country. The human developed index, it's 0.6, it's quite poor. So one story that perhaps is interesting to share is that we heard from those community health workers when they first received the tablets. This was like 4 years ago. Some of them, they actually cried, because they never been able to touch a screen with capability of filling your fingertips and providing answers to that. So that was the level of digital literacy that we found, up to the point that now they're actually very actively using those tools, and they are able to access the predictive results of our algorithms. So we move a long path, but again, just want to stress the point that that's not only the case that the country has a huge amount of people that are able to use smartphones, and that technology is getting less expensive throughout the years. Plus the cultural experience that we have. Usually Brazilians, they love novelties. So they tend to acquire these devices, even though they might not have actually the sufficient incomes to continue to provide the high tech, but they are able to drive their attention to novelties in terms of the health tech world. So that brings us a very interesting environment. So there's a social inequality, it's very high in the country, but at the same level, we see that we are able to scale up solutions based on digital solutions. And just to summarize this point, what we found is that when we look at two projects that we did, one is to follow our patients with COVID-19, again, in a telemedicine project, run with the government. So this is important. We are not separated. We're providing experience to the government to scale up the solutions. And with that in mind, the algorithms we run were able to have a very interesting accuracy in terms of predicting those that would need hospitalization. And this is, of course, a retrospective analysis. We need to make a randomized clinical trial to make sure if that is actually the case of using this tool. But the sensitivity was around 75% at the cut point that we chose. The accuracy overall was 80%. So that brings into the field that we must explore those predictive technologies in combination with where they are needed. So the idea was just simply provide a measure of severity so that the telemedicine system could provide help for those that need it the most. So I think that this is just a kind of sum up of what we've been doing in the country.
Thank you, Edson. And I'm sure one of the things we can get into as we move into discussion is when you talk about the potential with big data and predictive technologies, obviously the quality of data matters. And that challenge that came up earlier in the conversation with Dr. Pinto around in low and middle income country context, the quality of data. I think that's something, you know, in Brazil, that's a very different context than another country where we might look, and we have to understand what is the quality of data and how does that enable us to use big data, to use predictive technologies. So I hope we can get into that in our discussion. But I want to bring Farouk into this. So Farouk, mClinica works to connect fragmented pharmacies and emerging markets on a common platform. And I'm curious if you can speak to how the COVID-19 pandemic has presented both challenges and opportunities when it comes to your work and your model. And how could models like yours help to leverage the power of digital technologies to address chronic diseases, including cardiovascular disease?
Great, thanks, Catherine, and good to be with you all today. So I'm actually calling you from Jakarta, Indonesia, so right in the field here. And I think maybe it's helpful to set a little bit of context about the role of pharmacies in Southeast Asia. And I think, you know, the most amazing thing, and we did recent research on this, is that, you know, in a given year, patients will visit a pharmacy almost 12 times a year, whereas they visit a physician only 1.2 times a year. So they become a very critical point of care in the communities that they serve. And they're serving, you know, all types of disease areas from cardiovascular to hypertension and the like, and they become very, very important. When COVID hit, you know, it's very interesting to see what happened to the network. And, you know, we found that pharmacies were actually increasing volume of patients that were visiting pharmacies versus alternate, you know, areas like clinics and hospitals. And the reason why is hospitals were not taking on, you know, non-essential cases. A lot of the private clinics were closed. So actually, we found that there was increased load to pharmacies. And this really underscores the importance of pharmacies, not just for, you know, aiding in sort of COVID-19, but also becoming more and more of the primary care center. So at mClinica, what we do is we actually connect tens of thousands of pharmacies on a common mobile platform. About 80% of the pharmacies in Southeast Asia are actually independent mom and pop pharmacies. They don't have any sort of technology or systems. So we connect over 190,000 pharmacy professionals from about 45,000 pharmacies that have an estimated reach of around 150 million patients. So that becomes really important in terms of primary care. So, you know, in terms of digital intervention, we really did three things when COVID hit. You know, the first thing was that we found that as they became more important primary care points for the communities that they served, there was a greater need for education and literacy. And so across a variety of verticals, we did massive digital education and just bringing out, because of the topic of cardiovascular, you know, in a matter of about 2 weeks, we educated around 6,000 pharmacists on cardiovascular, right? So looking at signs, symptoms, how to counsel, how to do adherence monitoring, and really trying to strengthen this capacity because of the increasing role of the pharmacy professional. The second thing, what we found was that pharmacies were, you know, having massive stockouts of medicine. Supply chains were affected, and if you trace it back to the original source of APIs from China at the time, you know, a lot of this was just delays that compounded into drugs not be available at the pharmacy. So a lot of the work we did was in digital supply chain, ensuring that pharmacies actually were able to order the products, get cash flow and financing solutions for the products that they were purchasing, and really make sure that it was on the shelves. And I would say the third thing we did was on the digital patient management side. So really ensuring that when patients bought the drug from the pharmacy, that they actually had greater levels of counseling and adherence monitoring, making up for sort of the lack of other primary care sources, whether it be their physician or their nurse. And so we did a lot of the disease management aspect. In fact, during 2020, we put about 120,000 patients just on cardiovascular digital patient programs alone. So it's kind of interesting to see the role of pharmacy. It's increased, you know, vital role in the communities and using digital to help in terms of quality of care, availability of product, and adherence to end patient.
Thanks, Farouk. And I already see we have some questions coming in from the audience, so keep them coming. I will get to those in a moment, but first, I just love the opportunity to hear from each of you on the connections you see between your work, because you're each tackling these challenges from very different angles, each leveraging tech in the way that you tackle these challenges. But one of our tasks today is to discuss how do we harness this momentum moving forward. So from your different lenses, or if you'd like to comment on what you've just heard, why is this an opportunity? I mean, there have been huge challenges over the past year, but why is this also an opportunity? And how, from your view, do we harness this momentum? And if you want to build on what anyone else said, that'd be great. But maybe we'll go back to you first, Nneka. Oh, and Nneka, I'm not hearing you for some reason, although it doesn't say you're muted. So we might come back to you. There we go. Great.
Yeah. Okay, fantastic. So 100% it's an opportunity, as you've highlighted, right? It's completely upended the notion that digital can't work, right? So literally, which I think is crazy, but it's the one positive aspect of COVID, which has obviously been absolutely terrible. But just building on what Farouk has highlighted, it's really interesting because we saw, in the context of COVID, with service interruptions, et cetera, as Farouk is saying, people did go to pharmacies, right? And then at the same time, they started calling us. And we are focused on self-care, but it didn't matter, right? And all of a sudden, it was no longer just about my hypertension, right? It became, I'm bleeding, I've gone to the hospital and the gate is closed and they're not seeing me, what do I do, right? And so for us, it very much became, where are the boundaries, right, of self-care versus care? How do we build connections? How do we really ensure that we have this ecosystem of support where we're connected to pharmacies, where we're connected to providers, and we're all collectively working together? And what that requires is investment in digital for providers, investment in digital for pharmacies. So it's really nice to hear kind of what Farouk has highlighted, as well as Dr. Amaro, right, around kind of the partnerships, because I think we saw an acceleration of partnership in the context of COVID. How do we, continue that momentum, right, so that we're all working together to ensure that there is this integrated platform? The other element is, for us, the biggest struggles from the self-care perspective is that it requires devices. So to have data, when you're talking about cardiovascular health, people need blood pressure monitors, people need glucometers, they need scales, they need measuring tapes, and for them to be, that's just from a device perspective. And then when we talk about even kind of leveraging your phone for health, they need access to airtime, they need access to data. They need devices that have enough space, enough storage space for what you're asking them to track. And then we can go on and on about the literacy aspect. And so for us, we had to do mapping on our end to identify the pharmacies in the communities that Farouk is talking about that actually would offer for free or for at a low cost the ability for people to walk in and track their metrics. In addition, we set up in-person nudge hubs. So pre-COVID, we set up in-person nudge hubs. They're essentially kind of drive-by health, very small kiosks where people can track their metrics with the devices that we have, and also learn how to use their phone for health, or meet with a coach in person, or join group classes. But we shut them down in the context of COVID. And all of a sudden, members were clamoring, asking us to set them back up, because they were like, this is our only access to devices. We're not able to access places where we can track or where we can have that kind of support as well, and not just on the digital side. So I just think there are a lot of opportunities to look at kind of the gaps, right, in terms of the connections along the individual's journey of health from the self-care perspective, and at the service delivery point as well, and ensure that those gaps are closed, so we're truly ensuring that individuals are at the center of their care journeys for better cardiovascular health.
I love that description, and it's a helpful framing for our conversation today, to consider an individual's journey of health and what are the gaps and how can we fill those gaps, and the role of tech and partnerships in doing so. So I really appreciate that. Edson, did you want to jump in?
Yeah, I think that's actually the key point: connection, not only data connection, but people's interest connection. So in my particular case, what we've been experiencing is this link between universities, local universities, with the federal government, and again the private sectors, because you have to provide, as Neka just mentioned, a blood pressure measurement in a way that you can get data automatically from the instrument, which is actually very important for data quality. At the same time, one point that was also highlighted is the ecosystem. So we're not only thinking about one digital solution for a part of the patient journey. There has to be comprehensive somehow, or at least it has to promote links. If not possible, we cannot do everything all the time, but COVID-19 provided this kind of driven force for people to notice that it's not bad to conduct your healthcare in a different way. It's actually very helpful. So this is a major idea that was kind of latent before, and now we had to test it because of the obvious reasons. And by the way, now the country has peaked, and it's been very terrible for the past days here in COVID-19. So for instance, my state now is 1,200 people died. Yesterday actually was notified as death caused by COVID. So we're in the middle of the turmoil. So there's no other option for us if we want to expand the healthcare other than trying to use the scalable solutions that we're just discussing here. The point is the legacy. We have to provide and look forward and provide means to embed in our healthcare system data quality check controls, or the awareness that data quality is actually corresponding to life. And also the other point is that this has to be expanded beyond COVID. So we have to think about the legacy of our systems and the way we can use this as an opportunity to move ahead in reducing the social inequities. Because there's a way there. In other words, if you use these tools, you can get either the other way around, you can actually increase the disparities between access to healthcare, or you can work vice versa. That's why I think it's key to interact with the government, because these are the guys that makes the policies, and they have to learn from their own experience using their tools, interacting with the third sector. So I guess the connection is the point, people's connection and intention. And now we have unfortunately, major driving force, and it's impacting all of us. So we have to take this opportunity to move forward. And I think it's a major point to engage with the government and the policies.
I really appreciate you emphasizing the role of government and bringing Farouk into this. Farouk, I'm wondering if you can talk about the opportunity you see to harness the momentum. And can you also touch on this point of engaging with government and the role of government?
Yeah, actually, happy to. And I think, when it comes to the role of government, I think what's been really interesting is even how fast government has moved across disease areas, not just COVID-19 during this period. I think COVID-19 was a forcing mechanism for people to make, rapid change. And I think, just going through our own experience in Southeast Asia, we went from essentially doing very light work with government to, because we had this digital pharmacy channel, working with every single Ministry of Health in every single country in record time. And we never even thought there was a way to engage. I mean, governments were making, decisions in a matter of days, which would normally take months or years. And so we were doing work across tuberculosis, AMR, HIV, AIDS, NCDs as well, not to mention COVID-19 directly. So I think, what's happening is that, at least we have a unified point in the pharmacy, right? It is serving both the sort of patients that are under public care. It's serving the private market. So it becomes this interesting sort of intersection point for both the private and public sector. And so therefore the offering becomes interesting for both parties. And also the disease areas that they focus on are different, right? So we do really see that coming together. And I think you can't solve healthcare in a box. Healthcare is absolutely something that has blurred lines between public and private sectors. I think Neka and Edson have both mentioned this, and I think that's very much true to the point.
Thank you, Farouk. I want to bring in a few questions from our audience. So first, we have a question on community feedback, which I'm glad to see. And the question is around, how do you see communities' feedback especially in terms of having trust from community level service providers, where there is low tech literacy levels. Would be glad to hear more on how this has impacted service delivery. So I think this comes back to the issue of trust, the role of community health workers, which we talked about a little bit earlier, and the role of community feedback. So any thoughts on that question?
I may take up the first view on that, actually. So we have to empower these people through technology as well, but not only. I guess trust. If you're from the same community, I think it's easier for you to better understand the people's story because you know their lives. They are your neighbors. So that has a strength that you're from the community. So community health workers are a key element in the integration of healthcare everywhere. But not all countries are able to have this kind of facility. But again, deep into the trust, I think the actions must be linked to the proposals. In other words, if a person is actually providing the use of a particular app, so you install that in your mobile phone, but locally you don't see the effects, I think that this is actually very bad, of course. So the first experiences have to be guided. And I think that brings something that's beyond digital literacy. It's the people's trust and expectancy based on their own journey. So for instance, if you live in a country where the healthcare is provided by the government, you expect lots of things from the government. So you tend to be less prone to look at yourself as a major element in your healthcare, your own healthcare. So activating patients, it's also depending on how they see the relationship with the healthcare providers. Whereas in other countries where you don't have absolutely no healthcare or very difficult to access healthcare, even though they should be there by the regulation or by the places that you are, you have to live on your neighbor. So in other words, in Brazil, we have different scenarios. Sometimes we have a very good healthcare provided by the government because, it's not the same everywhere, although the policies are equally sparse throughout the territory. And I have to thank Dr. Pinto because it's been very helpful for the Brazilian Cardiology Society in order to promoting this model. I think we have good examples of social community interactions, but the trust goes beyond the person-to-person interactions. There's the government behind and there's company interest behind. So it's a complex interaction, but it has to be built between two people via technology. I think there's always people at the end of the line, no matter if we have AI helping us, but you have to connect to people. So, it's the human touch. So touch and touch is the balance that we have to make. And it's particularly relevant in low to middle income countries because these people know we have good things from technology, but how does that affect my life? The example comes from other people using those that are living together with them or close to them, or even connecting to them in a distant manner via, the social media, for instance. But you have to have human experiences mediating the trust.
Agreed. Nneka, you want to jump in?
Yes, absolutely. So we are actually really very much intentionally focusing on the building of trust. We've actually leveraged a couple of frameworks in the literature to adapt them to kind of what we understand, because it's so important. And we recognize too that we have to prioritize that initial framing of kind of that trust building in the first 48 hours of enrollment onto the platform, because if we don't, we're going to lose it. Mm-hmm. And we've seen that, and we've seen, just in terms of looking at our data, we've seen that translate into impact on engagement and impact on behaviors. We always use exercise kind of as our metric because it's the one measurement that does not require a device in the low-income populations that we serve, and we've seen a complete correlation. And so, but when you're functioning in this space where you're supporting people from a self-care perspective, but you're also helping them navigate, when they need in-person preventive or treatment-based care, it also gets a bit tricky. To Exon's point, kind of around the other elements and the other elements of the ecosystem that facilitate trust. So we've created a directory of healthcare services, facilities, and providers to help people know where they can go for quality care. And then we've created a feedback system, but it's based on the Institute of Medicine or National Academy of Sciences quality domains, the 6 quality domains. And we've intentionally focused on these 6 quality domains that underpin the patient's feedback system, so that the facilities then see it. They don't see that they're being blamed for care. They see rather an opportunity, right, along kind of these quality metrics. So they can leverage that as an opportunity to then improve their services from a quality angle with very clear guidelines on what they can do. Again, kind of looking at that ecosystem that Edson has highlighted, and recognizing in many of the low-income countries that we serve, sometimes there can be punitive measures if feedback is made public. So that's just one element. And then just to address the question more kind of around this low-tech literacy, we've built this omni-channel platform, and it's been difficult. We started out with a web-based platform, that was it. And we soon realized that it didn't matter that it was 70% smartphone ownership. People didn't have data, or they were like, no, the only way I'm going to communicate with you is SMS. And if we're really meeting people where they are, then we have to understand that and rather build that and integrate that into our system. So we've created that omni-channel platform so that regardless of who you are or where you are, we can meet you where you are, right? So that we can hear what your feedback is. And over time, when you build that trust, people will share. I mean, it's a privilege, quite frankly, just to understand what's going on with them and where so-and-so facility mistreated them or didn't treat them with dignity and with respect. And we, in our position, can leverage that and work with the facility to support them around, how to leverage that information from a quality angle. So I think it's tough. I think it's a tough situation, but it's an opportunity, for all players to kind of work together collaboratively to try to address the various elements of this.
Agreed. And speaking of collaboration, let me bring in another question here. And Farouk, I'm going to let you jump in first, and you can feel free to comment on the last question too, if you'd like. But it really builds on something Nneka was just mentioning. So one of the questions coming in from our audience is, COVID seems to have eliminated barriers when it comes to political will and policy. How do we maintain this openness and cooperation to advance solutions, including digital solutions? So we're seeing that opening as well. And when we talk about harnessing momentum, I think that's a really great question to throw in there. Farouk, did you want to jump in on that?
Sure. Yeah, so it's a great question. I think, what's amazing is how quickly governments went and passed policy, albeit sometimes temporary policies, to allow for things like the acceptance of telemedicine, the acceptance of electronic prescriptions, right? The acceptance of prescription delivery, for example, certain ICD codes that were no longer, or now applicable. So, they went through everything from reimbursement rates to essentially fixed fee calculations and changing everything in sort of record time. And I think what's interesting is that, at least in Southeast Asia, for years, people had been lobbying for a lot of these changes, especially in terms of digital tools. And then they were actually allowed through temporary sort of policies. Now the question is, post-COVID, what's going to happen? Are they going to tighten these up? For example, an e-prescription in certain countries is a WhatsApp message. Is that going to stay as a permissible, method? Or are they going to, layer on policies and security on top of it, which is probably needed, right? And so I think what we're going to see is there was somewhat of a simplification of a lot of the policies that needed to happen, just a trade-off for speed. So I think you're going to see that, post-COVID, when people surface for error, they're going to kind of, look at it. They're going to understand its necessity, but they're also going to moves to regulate it for things like patient privacy, security, and the like. But I do think it does kind of open up the window or the door, and it's very hard to shut it after this. I think what you're just going to see is them strike a balance between, allowing digital to go forward, but still doing what regulators should and make sure that patients are protected.
I think you're right. I want to bring in this question, even though we're running short on time, but I think it's important when we talk about the patient journey. There's a question specifically on women. And what are your thoughts on cardiovascular disease early detection in women? How is it done today? What can be improved by using tech? And then this person includes some statistics around cardiovascular disease being the #1 killer of all women, more than all cancers combined is heart disease. And also the challenge of women getting misdiagnosed with anxiety or depression following a heart attack. So just specifically zooming in on women, I wonder if any of you can share insights on how we harness this momentum for that patient journey. Of course, it looks different across different contexts, but any thoughts on that question? Go ahead, Neka.
Oh, I thought Edson was going to. Okay, so I mean, I can talk about it from our perspective and what we've learned. So about 3/4 of the people that we serve are women, and Nigeria today has the 2nd highest maternal mortality rate in the world. We're almost at the top, and our belief fundamentally is that a lot of the focus from a maternal health perspective has been on labor and delivery, maybe antenatal care, not necessarily focusing on quality of antenatal care, but very little focus. There's been very little focus really on the indirect causes of maternal mortality, and as well as what a woman is living with, right, across her entire journey, right? Whether it's preconception, pregnancy, after, or not at all, right? And so it's very interesting. So in Nigeria, we just started, as part of a broader project with JPIGO and HSDF, we were able to conduct a digital prevalence survey on women of reproductive age across kind of the different phases of their journey. And we found out that at least 40 to 60% of women were either overweight or obese. Majority of them had no idea even what a BMI was. There was immense discrepancy in the number of women who had been diagnosed with hypertension or diabetes and what we found, because we actually did physical and biochemical measurements at the time of the survey. And at the same time, I highlighted the obesity aspect, but we also saw that 50% of the population had anemia. Is that nutrition, or is that a nutrition issue? Is there kind of a connection between malnutrition and obesity issues that we're seeing? But all of these are precursors, right? And so when there's kind of this level of underdiagnosis or undiagnosis, a lack of knowledge, right? Even from a prevention perspective, and then inadequate management, along the women's journey, it sets them up. We're trying at Mdot, we leverage risk assessments when people enroll onto the program. So we use actually absolute cardiovascular risk assessments. The issue with that for us in our context, once again, is that they require things such as cholesterol, which in our context, as we serve low-income populations, a lot of times that's out of their reach to be able to pay for simple lipid profile. And so, we're trying to work with academia to understand better how we can, better assess, cardiovascular risk, the likelihood of developing a severe event over the next 10 years, but very intentionally working with women across their journey on managing their health, on understanding what a BMI means, understanding what blood pressure values mean, understanding what glucose means, and helping them understand in their ecosystem and in their journey how they can leverage the day-to-day to make the lifestyle modifications that they need to have better health. And we've seen increased self-efficacy, we've seen improvements in blood pressure in these women. I've highlighted the exercise duration. A lot of that's been seen in women of reproductive age in particular. And we've also seen kind of an impact as well just on diabetes too. So with kind of interventions, a lot can be done, but again, we're now looking at kind of partnerships with laboratories to see, can we reduce the cost of some of these labs that would help us do better prediction, in support of their journey of health.
So interesting to hear that maternal mortality connection. And I think it comes back to what you said earlier about the patient journey and closing the gaps. And it's not just in cardiovascular health, but NCDs more broadly and health more broadly. It's that person's journey and how do we fill the gaps and form partnerships across that journey. So we only have about a minute left here in our panel discussion before we move to the next segment of our program. But Farouk or Edson, I want to see if there are any reactions from either of you. And let me just broaden the question here, because our mandate today is to talk about how we harness this momentum moving forward. And I think a lot of what we're discussing is how to go from reactive to predictive, preventative moving forward. So any final thoughts on how we harness this momentum? Maybe 30 seconds max.
Okay, 30 seconds.
Go for it, Edson.
So I'll just jump in with the child mortality ratio. So one way to move forward is to be proactive. So for instance, we have done one project with the social media application in the country that is actually adopted by 12.3% of all pregnant women. And what we did was to look at natural language processing to see if we were able to predict the low birth weight and also the premature kids in that population. That was done in combination with opinions from professional nurses. Again, this brings in the idea that I mentioned, that people are talking, so more than 100,000 pregnant women were discussing in the social media, and they were able to tag those that were at high risk pregnancy. And that brings into the question that the fact that they were at high risk is much more linked to their pregnant condition, that is overweighted, and of course hypertension. So I think this is one way to move up, is actually to bring on this awareness before they give birth to their babies.
Thank you, Edson. Farouk, any final thoughts? Where do we go from here? How do we harness this momentum quickly?
Yeah, so I think, for us, it's really about looking at, the pharmacy as this primary point of care. And I think what it requires is really looking across the whole spectrum, from screening to referral to testing to adding it. And I think, if we put Edson and Nika and maybe myself and a few others in a room, perhaps we can strengthen a lot of the great work that each one of us is doing. It seems like there's a lot of complementary aspects to what we're all doing, and it would be awesome to work together. So maybe there's a future collab. So great to you guys as well.
Well, that's the goal, putting you all in this virtual room today. So please do form those connections. Head to the chat. Thank you so much to our panelists. And now I want to move into this last bit of our programming here. And I'm really thrilled to welcome Jason Shelaby, who's the Director of Global Health Policy at the Novartis Foundation. Jason, we covered a lot of ground, but I'd love to hear from you any reflections you have, and hopefully we'll also get to learn a little bit more about what the Novartis Foundation is doing when it comes to improving cardiovascular health. So go ahead, Jason. What do you think of the panel? What can we do in this virtual room to harness this momentum?
Well, yeah, I just want to thank again, Catherine, and all the great speakers today, because I think we've seen this urgency, but also this capability that really to reimagine how we improve cardiovascular health, given this tsunami that's been described, right, and created by COVID. So, in short summary, I think, there's really this change in perspective on the usability of digital and tech. It's really been upended, right? I think we've heard some of these examples, right? So we're seeing digital solutions and the integration of predictive algorithms that are scaling across countries and demographics. I think it's really exciting. I thought the story from Edson around the community health workers, again, shows this is reaching scale and fast in all settings. And I think as well, this importance of kind of innovating and shifting care in the community, so while strengthening this connection between the individuals, healthcare system, public and private actors, and as well as broader ecosystem of support with government, and thinking about the policy changes that need to take place. And I think that's one of the things that's definitely coming out, which is how do we harness this momentum, right? How are those new regulatory, barriers that have been removed, or new innovations? How do we keep this up now that the cat's out of the box, so to speak? But we've also seen some of these challenges around, how do we keep this element of trust at the forefront? We address it on the onset, whether it be with individuals, how we introduce these new solutions for them, but also around how do we build the quality of data so that this trust can be around this as these new global initiatives come in and seek to leverage insight from it. So yeah, again, thanks again for a really fascinating conversation here.
Thank you, Jason. And just for those who want to learn more about what the Novartis Foundation is doing specifically, I know earlier Dr. Pinto mentioned the observatory work. Where can they learn more about that, or what are any other relevant initiatives they might check out?
Absolutely. Yeah, we've been working around on cardiovascular health issues for several years, and actually have introduced this cardio framework, this engagement model that looks at multiple kind of evidence-based strategies, and that we encourage people to come and visit it as well on our website and see some of this that's coming up in the next few months. But one of them is really around this question of data, right? And as you said, as Professor Pinto said, data is knowledge. how can we apply, and improve the capacity to analyze digital and data solutions and apply machine learning to really derive the right insights and also improve policymaking. And right, so they're working, the World Heart Federation, on this global observatory for cardiovascular health. And we're really excited as well to partner with them with this data collaborative that we're building to really help provide that an analytical capability that we really hope can bring new insights and really help as well shape policymaking around this important topic. So again, thank you so much for the time today, and to you and to all the speakers. It's really an exciting, important topic, and I'm glad we addressed it today.
Thank you, Jason. Agreed. And I just want to close by saying, we explored today how the global health community can build on this momentum of increased, not just use, but trust in virtual health and care service. And I think there are takeaways, not just for people working on cardiovascular health, but working across that patient journey and opportunities for collaboration. So I hope not only that those of you joining us today got some interesting takeaways for your work, but also that you've formed connections here in the chat. So I encourage you to follow up and form connections and continue the conversation. I want to close by mentioning that the Novartis Foundation will be partnering with Devex at the World Health Assembly, where Devex will be hosting events across 3 days, covering everything from vaccine rollout to pandemic preparedness. Keep your eyes open for more information on these events. And of course, stay tuned for more on these topics from Checkup, which is our weekly newsletter on all things global health. Thank you so much.